Dear colleague, welcome to this presentation of DBS for OCD and the fifth and concluding part of the course on DBS for psychiatric disorders for psychiatrists. We have in the two previous lectures looked at DBS as such, and on the whole field of psychiatric neurosurgery. However, while DBS is under investigation for a number of different conditions, it is an unestablished therapy only for OCD, and that is the topic of the current lecture. If you are watching this lecture, you are probably a psychiatrist and well aware of the characteristics of OCD. But let us shortly recapitulate the basics in case some neurosurgeon is watching. OCD is characterized by anxiety-driven, intrusive thoughts, obsessions on specific themes that lead to repetitive behaviors or rituals, compulsions, to relieve the anxiety. Typical obsessions include contamination, symmetry, causing harm to others, blasphemy, and sexual thoughts, while compulsions might include washing, cleaning, counting, ordering, checking, and such. The patients are normally aware that their compulsions does not make sense, but perform them anyway in order to relieve the anxiety. And for a diagnosis, according to the DSM-5, the obsessions and compulsions need to take at least 1 hour of the day and cause suffering and a reduced level of functioning in daily life for the afflicted. Mother Nature does not always organize everything as neatly as we physicians do, and in real life there will often be an overlap between different conditions. Obsessions and compulsions can be part of other psychiatric conditions, and OCD needs to be distinguished from other anxiety disorders such as generalized anxiety disorders and phobia, ruminations in major depressive disorder, and OCD-related disorders such as body dysmorphic disorder, skin picking, and trichotillomania. Further, common comorbidities of OCD include anxiety and mood disorders, and severe OCD, with which we will be dealing in this lecture, is associated with higher rates of neurodevelopmental disorders such as autism, attention deficit hyperactive disorder, and Schiller-Tourette's syndrome. And such comorbidities can sometimes create a rather complex clinical image. And the severity of the disorder is usually measured with the Yale-Brown Obsessive-Compulsive Scale, Y-box, consisting of 10 items based on which the condition is graded as mild, moderate, severe, or extreme. Without treatment, the prognosis is poor, and the majority develops a more chronic disorder. The standard treatment options for OCD consist of cognitive behavioral therapy, CBT, and pharmacological treatment, but about 25% of the patients are deemed treatment-resistant. Those treatment-resistant patients might, when suffering from severe OCD, be candidates for surgical treatment, and since up to 2% of the population has been estimated to suffer from OCD, this has led to some very high estimates regarding the potential number of patients who could be treated with DBS. On the other hand, the paper here to the right has suggested that the pool of potential surgical candidates is very small. No one really knows for sure, and perhaps the truth lies somewhere in between, and there is probably a significant number of patients who would benefit from DBS, but who, for various reasons, are not offered this possibility. Anyhow, we have in the previous lecture looked at the development of psychiatric neurosurgery for OCD, and we have today two different methods, lesional surgery and DBS. Lesions were initially done using open surgery. A thin electrode was introduced into the same areas as we are now stimulating with DBS, and then heated in order to create a small lesion, as you can see here. Such lesions can also be created with incisionless techniques such as a gamma knife surgery and focused ultrasound. And to judge from the scientific literature, modern lesional surgery is not inferior to DBS concerning the effect, nor is it associated with more complications. However, DBS is today more commonly used, probably due to its reversible nature. And DBS for OCD is since 2009 CE marked in Europe and FDA approved in the USA as a humanitarian device exemption, why we will focus on DBS in the current presentation. The most common model for the pathology in OCD is dysregulation in the corticostriato-thalamocortical CSTC network. The CSTC network is a closed-loop circuit that runs from the cortex through the basal ganglia to the thalamus and then back to the cortex. In the basal ganglia, the network divides into a direct and an indirect circuit. Normally, these circuits balance each other, where the direct pathway is an excitatory pathway regulated by the inhibition of the indirect pathway. In the model for the CSTC pathology in OCD, there is an imbalance in these circuits, with the direct circuit being overactive and the indirect underactive. The net result of overactivation in this network is believed to contribute to the excessive anxiety-related thoughts, the obsessions, that drive the corresponding excessive behavioral response, the compulsions, which is then reinforced by the activation of reward circuits by the temporary anxiety relief from the compulsions. However, while this might be the most important circuit in OCD, it is not the only one, and reality is undoubtedly more complex than the models. We looked in detail at how DBS works in a previous video, but basically, by implanting electrodes into the brain, we can introduce new impulses that will block the pathological signals in this network and hence the symptoms. As we discussed, findings from DBS in the subthalamic nucleus in Parkinson's disease led to the development of DBS for OCD in or close at the STN. However, most patients are being implanted in the area of the old lesional targets in or at the internal capsule. To recapitulate, capsulotomies were performed mostly in the anterior part of the internal capsule, and DBS was first performed at the same location. But due to a better effect, the electrodes were gradually moved further posterior, and some groups targeted the nucleus accumbens but seems to have achieved the best effect from higher contacts located in the internal capsule. Even further posterior, in the inferior thalamic peduncle, good results have been reported in a few patients. And between these areas is the bed nucleus of stria terminalis, which I myself are using. And recently a more anterior target in the ITP was introduced, but this must be overlapping with the BNST target if one looks at the location of the electrodes, and especially if one takes into consideration the size of the volume of neural activation. Considering the large VTAs, it is difficult to know what we are stimulating and what is the best target in this area, and we are probably entering the same or connected networks at different points, and the internal capsule, BNST, VCVS, accumbens and perhaps also the ITP could be seen as more or less one single target. Thus, I believe that we might have more targets for DBS in the literature than in the real world. But perhaps this is more of a terminological question than a clinical, since the outcome of DBS in these targets seem to be very similar. So, which patient should you refer? Well, I think that you should be generous when deciding whether to refer a patient for evaluation of possible DBS. If you are only referring excellent candidates for DBS, then it is likely that you are missing patients who would have done well with DBS. And it's better to let the DBS center discard unsuitable patients than to miss patients that could be helped by DBS. Thus, please remember that you are not referring patients for DBS. You are referring patients for evaluation and consideration of DBS, with the final decision left to the DBS center. Hence, there are no risks with referring patients that might not be optimal candidates for DBS. With that said, you can of course not refer all patients with OCD. You need to apply some selection criteria. So let us look closer at some typical inclusion criteria for DBS. The selection criteria will differ between different groups, but these are rather representative. Most centers will not operate patients below the age of 18 and not too old patients. The opinion on what is too old might differ, but 70 years is often seen as the upper limit. The patients should have severe and therapy-resistant OCD, diagnosed according to the criteria in the DSM-4, with symptoms for more than 5 years, causing the patient suffering from substantial incapacity because of his or her symptoms. A cutoff level of 25 according to Y-box is often used, but most patients treated with DBS will have a higher score. The patient's symptoms should be therapy-resistant, defined as no significant or sustained improvement with at least 3 different SSRI in adequate dosage for at least 3 months, and with a trial of a combination with a neuroleptic. Further, with adequate trials of exposure response prevention CBT, or failure to complete the CBT due to the severity of the OCD. There should be no concomitant substance abuse or other psychiatric disorder so severe that it might jeopardize the treatment. And finally, there should be no surgical contraindications. When a patient is referred by his or her regular psychiatrist, the patient will be evaluated by the DBS team. The exact configuration of this and the details of the evaluation will differ between different centers, but I think that my own group is rather representative, and I will use this as an example. The patient will visit us on 2 or 3 occasions before surgery. The psychiatrist will, with the help of the DBS nurse, evaluate the patient in detail regarding symptoms, diagnosis, other psychiatric disorders, previous treatments, and of course regarding suitability for DBS. The neuropsychologist will then evaluate the cognitive faculties, and the neurosurgeon will make sure that there are no surgical contraindications, that the general health condition is acceptable, and that the patient has a reasonably healthy brain as seen on MRI. Further, we will discuss the details of the procedure. And all of us will discuss the aims of the procedure and what is reasonable to expect. We will further ask the patient to write down their goals. We will ask them to define what they want to achieve and with what degree of improvement they would be satisfied, and what impact they would expect this to have on their life in general. It is very important that the patients have reasonable expectations, and a well-informed patient is a prerequisite for a successful therapy. However, this can be a challenge with some of these patients. For that reason, we will also provide them with written information and ask them to watch 2 videos on YouTube before coming to us for evaluation. The first video deals with the surgery and DBS as such, and the patient will then continue with the next video covering DBS for OCD. The idea with these presentations is that they will here get the same information as at a consultation, but in a more detailed and pedagogic manner. After the evaluation, only about 1 of 3 referrals will be accepted for DBS. Most often, this is simply because we deem that it is unlikely that the patient would benefit from DBS. In most cases, the patient has OCD, but it is deemed that much of the patient's symptoms and suffering is caused by other disorders that would not respond to DBS, and that DBS in the end would not improve the quality of life of the patient. In those patients found suitable for DBS, we will then proceed with surgery as discussed in a previous lecture. In OCD, the energy consumption is often high, and a non-rechargeable IPG will typically last for a few years, while a rechargeable IPG with a lifetime of up to 25 years is often, but not always, preferred. And at surgery, we confirm that the electrodes have ended up in the intended target in the brain, and an exact understanding of the location of the electrodes is of value when it is time to select the stimulation parameters. The stimulation is sometimes started immediately after surgery, but it is often delayed with some weeks in order to let the edema around the electrode vanish. The effect of stimulation is evaluated for the individual contacts, but the immediate effects are often modest in OCD. The patients will receive a remote control with which they can check the stimulation, that it's working properly, and also get information about the battery status. This remote control is sometimes used also to make minor changes of the stimulation parameters during the titration of the stimulation. The effect of OCD will not develop over days, but over weeks, months, and even years. The effect is initially mainly seen regarding the anxiety connected with the OCD symptoms, and this will reduce the need for compulsive behaviors to alleviate the anxiety. In most patients, most of the effect on the OCD will have developed after 1 year, but in some patients it will take even longer, and typically minor further improvements will be seen over the coming years. During this process, the stimulation will be optimized and gradually increased. Some centers will be very active with frequent evaluations and changes of the stimulation, while others will make a few changes during the first year and then even more seldom. Typically, the stimulation strength will be increased over time. This gradual and slow increase of the stimulation is done in order to avoid the development of stimulation-induced side effects, such as sleep disturbances. The process of optimizing the treatment is not limited to the stimulation. Over time, the pharmacological treatment will also be evaluated and optimized. However, when starting the stimulation, it is often better to avoid changes of the medication in order to know what changes in the patient's status that can be attributed to the stimulation. Further, these patients will often receive CBT. It is true that they have normally already tried and failed this before surgery, but the idea is that they might be more receptive to this once the stimulation has started to reduce the severity of their disease. We discussed complications of DBS in general in the first lecture, and you will find lectures at our webpage covering this topic in detail. I will not repeat all details here, but will focus on clinically important complications and OCD. Further, we have understood that many of the psychiatrists who are considering to refer patients for DBS are refraining from doing so due to fear of potential complications, why I will try to put this in perspective. DBS is, at least from a neurosurgeon's perspective, a very small procedure, albeit technically advanced. We make a small skin incision and a burr hole, and then we gently introduce a thin lead into the brain, and that's it. Hence, severe complications of DBS are rare. One might also assume that they should be even more rare in DBS for OCD, considering that most patients are young and in good physical condition, while many of the patients undergoing DBS for movement disorders are elderly persons with progressive neurological diseases and often other concomitant conditions. This is true also regarding the brain of the patients, where OCD patients will have healthy brain as seen on MRI, while many elderly patients with movement disorders have so pronounced degenerative changes that DBS is contraindicated. And this should be of importance concerning the two most relevant surgical complications that are also most often the source of worries among patients and referring physicians, and these are infections and hemorrhages. This is a recent review of the risks in DBS for OCD. In total, sufficient data was found from 249 patients. 2.4% of these patients had infections necessitating removal of hardware. 1.6% suffered intracerebral hemorrhages, of which 2 patients had prolonged symptoms in the form of a finger palsy and dysarthria, respectively. 3.6% had postoperative seizures, of which 1 patient had more than one. These figures suggest, at least from the perspective of a neurosurgeon, that DBS is a very safe procedure with few complications of a serious nature. Just to add a more personal perspective, in my own experience of more than 600 DBS procedures, we have an infection frequency of about 2%. One of these occurred in a patient with extremely severe OCD. The patient had previously been confined to a psychiatric ward for the last years, but responded very well to DBS and was after some years in complete remission. Unfortunately, the patient fell from his spike and suffered a wound over the IPG, which became infected and had to be removed. The patient immediately regressed to his previous condition and was again confined to a psychiatric ward, but had a complete recovery once the DBS system was replaced after some months. The infections seen in DBS are usually confined to the vicinity of some part of the implants. It will in itself not be very dramatic, but the major problem is that you have to pause a very effective therapy. I have over the years seen a total of 4 hemorrhages in Parkinson's disease and dystonia. 2 of the patients complained of headache on the day after of surgery. A CT demonstrated a minor hemorrhage and the symptoms were in regress within hours. A third patient suffered a clumsiness in one hand, while the fourth patient had some weakness in a leg and an arm. Both these patients were completely recovered within a few weeks. None of these hemorrhages necessitated any interventions, but I kept the patients for an extra day in the ward just as a precaution before they returned home. Thus, even if it is true that among 230,000 DBS procedures, often in elderly and fragile patients, there have been a few deaths, and that these have most often been caused by hemorrhages. A hemorrhage will in most cases not be very dramatic, not necessitate any action, and the patient is in most cases expected to suffer no persisting harm. Regarding seizures, I have only seen this in 3 patients and always during surgery, and this was of such short duration that they were over before any action could be taken, and none of the patients had any further problem related to this. Thus, we are here talking of isolated seizures and not of the development of epilepsy. Stimulation-induced side effects will vary between different targets. Immediate stimulation-induced side effects are in the most commonly used targets typically discrete when compared to the situation in DBS for movement disorders, such as increased anxiety, and the stimulation will be set at a level below the side effect threshold. Other side effects take longer time to develop and identify, such as, for example, mild hypomania and sleeping disturbance. If such side effects are encountered, then the stimulation settings are changed. Sometimes it is a question of how fast the stimulation strength has been increased, and it might be sufficient to temporarily lower the current for some weeks, after which a new attempt can be made to increase it again. Another worry sometimes raised is the risk for cognitive side effects. DBS is in general well tolerated, but this question is very relevant in neurodegenerative disorders such as Parkinson's disease, where a majority of patients will eventually develop dementia, and who might be more prone to be negatively affected by an invasive procedure. Thus, cognition has been well studied in those patients and deemed to be of little negative consequence, even if a minor affection of verbal fluency has been found in many studies. In OCD, the reports on cognition seems to confirm that this is not an issue. Actually, one of the commonly used targets for OCD is very close to the fornix, where DBS has been reported to improve cognition in some patients with Alzheimer's disease. However, this has not been reported following DBS for OCD. Another concern sometimes voiced is the risk for personality changes. This concern seems to mostly originate in the perception that if we are attempting to affect psychiatric symptoms, then we might perhaps at the same time affect also the psyche, soul or mind of the patient. To judge from the literature, there is no such risk. However, the situation is slightly more complex, because if we administer a personality test such as DIP-Q to these patients, many will display pathological personality traits secondary to the psychiatric condition, and these can indeed be affected by DBS, but this is interpreted as a return to the patient's pre-morbid personality. Here we have an example from 2 of my own patients who displayed significant pathological personality traits before surgery, which were improved with DBS. Thus, the risk for serious adverse events in DBS for OCD is very low, but another question is, what level of risk is acceptable? Not seldom I will be contacted by patients who seem to be good candidates for DBS, but who will not be able to procure a referral from their psychiatrist, and often they report that the psychiatrist deemed the procedure to be too risky. To me, the patients referred for DBS for OCD often seem to suffer more from their condition than the patients with movement disorders referred by neurologists. Further, the percentual improvement from the most common DBS procedure for Parkinson's disease is about the same as what has been reported for DBS for OCD. Psychiatrists are much more reluctant to refer patients compared with neurologists, and this must be due to a different risk-benefit analysis, and I would guess that this is especially true regarding the perceived risk. The risk analysis must of course take into consideration also the possible reward, that is, the effect of DBS on the symptoms. The evolution of DBS has by necessity been slow. DBS can be seen as a handicraft, and we will typically proceed with small non-randomized studies until we believe that we have gained a sufficient experience regarding a new procedure and have refined it to such an extent that we are ready to proceed with randomized studies. The effect of DBS in the individual patient depends on a number of factors, including target selection. There are several different structures in the brain used for DBS, some of similar efficacy, but it is unlikely that all of them are identical, and we need to learn not only which target to target, but also exactly where in the individual targets to place the electrodes. Further, it is not uncommon that some electrodes do not end up exactly in the intended target. To learn to understand how the programming can be optimized within this target takes time, and the patient selection is likely to be of great importance, and we still have a limited understanding of which patients will respond well and who will not respond at all. Further, we need to gain experience of how to combine this therapy with the pharmacological treatments and CBT. Regarding DBS for OCD, a lot remains to be understood, but we have learned a lot over the last 20 years, as demonstrated by the fact that we have now produced 6 randomized double-blinded studies, and that the therapy have been refined to such an extent that all of them demonstrated a significant effect of the treatment. For a psychiatrist, the number of patients included in these studies will seem small compared to many pharmacological studies. However, this is, as I mentioned, the manner in which stereotactic functional procedures do normally evolve, and this was also true regarding DBS for movement disorders. For various reasons, but mostly due to the rarity of the procedure, it is likely that we will not see any significantly larger randomized studies until DBS for OCD has become more common. These randomized studies all demonstrated DBS to be superior to sham stimulation. In some of them, the actual improvement on stimulation was modest, but this has probably much to do with the short evaluation period, and we see that the effect was considerably better under the longer open phase, when of course also a placebo effect might be present. Unfortunately, for ethical reasons, no one has yet made a double-blind study over a longer period of time, why we here have to rely on the open, non-randomized studies. If we look only at the studies in the area of the internal capsule, then the result after 1 year of treatment seems to be close to 40% regarding the reduction of Y-box, with a response rate of about 50%. This means that on average the participants went from suffering from the upper range of severe OCD to the mid-range of moderate OCD. The effect of DBS is thus not instant, but will develop over months and years, and it is not sufficient to look at the results after 1 year. Here, as an illustration, we see my first patients with up to 6 years follow-up, and in order to catch also the late responders, we need a longer follow-up. In this previously mentioned review of 249 patients, the improvement was 47% at the last follow-up, and the long-term outcome was nicely summarized in this review of 155 patients followed for at least 36 months, after which the mean improvement was also 47%. Also after that time, half of the patients were responders, a quarter partly responders, and another quarter non-responders, a pattern reported already by Lars Letzell for capsulotomies. And it's important that we explain to the patient that a mean improvement is a statistical construction and that we cannot predict the outcome in the individual patient. As demonstrated in this study on 70 patients, we have a very limited understanding of what is causing this difference, and we have no possibility to predict which patient that will benefit from DBS and who will not. With that said, a mean improvement of DBS of 47% or 14.3 points reduction of Y-box compares well with what has been reported from CBT and very well with pharmacological treatments, and we need to keep in mind that the patients with DBS for OCD consist of a highly selected group with severe therapy-refractory symptoms that have already failed multiple pharmacological and CBT treatments. So let us make a comparison with DBS for Parkinson's disease, just to put things in perspective. DBS is a well-established therapy for Parkinson's disease and other movement disorders. About 230,000 patients have been operated with DBS for this condition. OCD is much more common than Parkinson's disease. DBS for PD, Parkinson's disease, is indicated only in a minority of patients. DBS for OCD is indicated only in a minority of patients with severe therapy-resistant symptoms, but it's not clear how large this group is. DBS for OCD has been demonstrated to be effective in 6 small double-blinded randomized studies. The symptom reduction over time is around 47%. This is very similar to what is achieved in DBS for Parkinson's disease. Considering age and other factors of the patient population, DBS can be expected to be less risky in OCD than in Parkinson's disease. Still, only about 350 cases of DBS for OCD have been reported during the last decades. As I mentioned in the previous lecture, there are probably many reasons for the low penetrance of DBS for OCD. However, the most important reason is probably that the revolution of DBS for movement disorders has not been driven by the neurosurgeons but by the neurologists, and the psychiatrists have not embraced this treatment. At least in Sweden, most psychiatrists are unaware of its existence, and most patients will learn of DBS through other sources. I hope that we in this presentation have been able to provide a correct description of this treatment and that you have found it to be of some interest. And with that, I end this overview. If you are interested, more detailed presentations are available at the Stereotactic Academy. Thank you for your attention.